Now, I mentioned earlier on that the holy grail really of new drugs in diabetes is got to be an agent which has effect on reducing cardiovascular events, because that's what people die from. And we've been waiting for drugs that achieve that for some time. And there have been a host of large trials being conducted over the last 10 years with the new classes of agents to establish whether or not, what effect they have on cardiovascular risks. And we've had two big trials released, one this year just in July and one at the end of last year, which actually finally give us some evidence that these new agents are worth the money, really, I think. So this one is liraglutide. So liraglutide is a GLP-1 agonist, so it's like the exenatide, liraglutide, and this was a trial in cardiovascular outcomes in type 2 diabetes. And apologise for the smallness of the slide, but the important thing here to see is this is liraglutide versus placebo, and the primary outcome in this trial was a composite outcome of cardiovascular events. So it includes non-fatal and fatal myocardial infarction, stroke, hospitalisation for heart failure, death from cardiovascular diseases, etc. And what you can see is that the lines separate here, and that there is a reduction in the risk of these events with liraglutide versus placebo. And that was consistent really across the endpoints that were part of that composite endpoint, although not all of them individually reached statistical significance. They did when you put them all together. So I think a really important trial to finally show us that some of these new agents actually do have meaningful reductions in the events that we actually want to target. I'm just going to skip over that. It's a very complicated slide, and I don't want to bore you with the details, but essentially it starts to break down what some of the subgroups of individuals who might benefit the most. And it tells us that those people who have had diabetes for the shortest period of time versus a long period of time benefit most. It shows us the people, was the other thing that I wanted to pull out, people who were more obese benefited from this drug more than people who are leaner. And that's interesting because of the composite way that the drug works, as I mentioned before, in terms of weight loss and satiety, etc. So showing us that that group of individuals might well be the individuals to target with a drug like this. So,
Jeremy, can I just ask, is it evident yet whether it's a class effect with the GLP-1?
No. No, it's not. You know, unfortunately, this is the first of the big trials from the GLP-1 agonists to come out, showing us this benefit. You might hope and assume, but we've been burnt before, haven't we, by making assumptions about class effect in drugs. So obviously the makers and sellers of liraglutide are active, trying to get promote their agent. All right. Unlike DPP-4 inhibitors, which are a tablet which is taken once a day, which is what we want, the GLP-1 agents, because they're a peptide, can't be given as an oral preparation. They have to be given as an injectable agent. Now, when you're having that conversation with a person where they're on maximum metformin and possibly a sulfonylurea, and you're thinking, well, what's the next step? Are we going to go to insulin or do something different? Many of them don't want to go to insulin because of injections. And so here we are offering them an agent which is also an injection. Exenatide, which is the one that's available in New Zealand at the moment, is actually given as a twice daily injection, whereas it does have a weekly preparation, and liraglutide, which is the one I've just shown you in the previous study, also has a weekly preparation, which is a lot more palatable, I think, for people than thinking they're going to go into multiple daily injections or daily injections. It's a very good point. Sorry, thank you for raising that. So what are the pros and cons of GLP-1 agonists? Well, the pros are the benefit in HbA1c and the new data to show the cardiovascular risk. In addition to that, they don't cause hypoglycemia. Of course, if you combine them with insulin, then you might have hypoglycemia, but on their own, as a class of agents, they don't cause hypoglycemia. They generally cause weight loss, and that can be as much as 5 to 10 kilos of weight loss, which is pretty meaningful in this group of people. There's been this buzz around the idea that they may preserve or even regenerate beta cells. I am not convinced by that myself. A lot of that data has come out obviously from rodent data. It's pretty hard to get human pancreas data when you're doing these studies. I'm not convinced by that at all, but it's a watch this space concept. The cons of them, definitely nausea and vomiting. Compared to the DPP-4 inhibitors, which are well tolerated, almost everybody that goes onto a GLP-1 agonist will get some nausea, particularly early on. It's a bit like metformin, you know, you put them on metformin and everybody gets a little bit of tummy upset and eventually comes right. Virtually everybody on these agents gets nausea, and for some people it's enough that they just can't take it, they just can't tolerate the drug, even if you leave them on a low, you know, half the dose for a long period of time. So it's definitely one of the major cons. The other thing that's hung over both DPP-4 inhibitors and GLP-1 agonists has been some early suggestion that they might potentially cause pancreatitis and worse still pancreatic cancer. And you could think conceptually how that might be the case, because you've got an agent, a drug, which is actually targeting specifically receptors in the pancreas. So conceptually you could see that could be the case. But I think the smoke is clearing on that now. We're getting a bit more of a clear picture. And the consensus view on it is that actually when you look at people with type 2 diabetes, people with type 2 diabetes compared to the rest of the population have higher rates of pancreatitis anyway. They also have higher rates of pancreatic cancer anyway. And when people have drilled down on the data from these trials and also looked at cancer registries, there's no convincing evidence that these classes of agents increase the risk of either pancreatic cancer or of pancreatitis over and above the background rate for people with diabetes. So I think you know, people are still going to be watching this issue very closely, but at the moment that is the sort of the view, and that's certainly the way I'm counselling people when I talk to them about using these drugs. So the other class of agents that I want to talk about are the SGLT2 inhibitors. And this is a fascinating concept really to me, I think. You know, historically, if you go back more than 100 years, if you suspected somebody might have diabetes, you know, you see those classic stories of the, you know, professor getting the medical student to dip their finger in the urine and taste it and see if it's sweet. And if there was sugar coming out in your urine, then you had diabetes. So, you know, conceptually you think, well, that can't be a good thing. We better stop too much sugar going out in the urine. And here we have a class of drugs which has now been developed specifically to increase the amount of glucose we pass out in the urine. So the way that sugar or glucose is handled in the kidney is filtered through the glomerulus, and most of it, virtually all of it, is reabsorbed in the proximal tubule. And it's reabsorbed actively through a channel called the sodium glucose-like transporter 2. So it's actively reabsorbed at that point, and very little glucose will get out into the urine. Our renal threshold for glucose is about 10 millimoles per mole. So if our serum glucose, or plasma glucose level is about 10 or above, we start leaking glucose out into the urine at that point. But below that, we absorb it. We're very effective at reabsorbing it. So this class of drugs has been developed essentially to inhibit that sodium glucose-like transporter, which means that we can't reabsorb all the glucose that is filtered, and we end up peeing out glucose even when our blood glucose is lower than that renal threshold of 10 millimoles per mole. Now, the interesting thing about that, if you think conceptually, is that therefore not only are you lowering your glucose, the action of that is completely independent of insulin. So it doesn't matter how insulin resistant you are, it doesn't matter how stuffed your pancreas is and can't make insulin anymore, this drug is still going to work because it's completely independent of that action. What it does imply is you've got to have kidneys that are working. So the one limitation, or a limitation, of this class of drugs is that as our renal function declines, then this drug becomes less effective. And so once your EGFR drops below about 45, you don't get a heck of a lot of action of this drug. The other benefit is that if you're peeing out glucose, you're peeing out calories. And it's estimated that you lose about 70 grams of glucose a day with a drug of this class, and that equates to about 280 calories per day. which is not insignificant if you think about it on a daily basis ongoing. So consequently, you might expect that you're going to get some degree of weight loss, or at least facilitation of weight loss with this class of drugs. The second thing, or the third thing, is that in addition to losing glucose, you actually lose some sodium as well. And so by losing sodium, that can have a beneficial effect on blood pressure. So again, we're looking at a triple whammy in terms of the benefits you might expect to see for someone with diabetes. So I think we've just covered that really. Increased loss of glucose, independent of insulin. Again, because of its mechanism of action, it doesn't cause hypoglycemia. Benefit on weight and blood pressure and renal effect. Now, side effects. All drugs have side effects, of course. The issue, most common issue with this class, and they're commonly called the flozins, is that if you've got increased glucose in your urine, you are at increased risk of infection. And that may be bacterial urinary tract infections, but more commonly it's actually thrush that people get. And what we've observed both in the clinical trials we've taken part in and also in real world practice is that if you, on this drug, if you get one episode of thrush, you're probably going to keep getting it. So some people just seem to be prone to it, in which case you may as well change to something else. But that's the most common side effect. The other thing that's emerging, and this is still a watch this space with this drug, and it may ultimately become more important, it's hard to know, is that we're seeing diabetic ketoacidosis occur in people on this agent. Now, because it is a drug which works independently of insulin, it actually is effective in people with type 1 diabetes as well. So people were starting to use these drugs, these flozins, in people with type 1 diabetes as an adjunct to their insulin therapy. And then there was a smattering of case reports of people who were presenting with ketoacidosis. And the slightly concerning thing about it is that unlike normal ketoacidosis, if you suspect that in a patient, you check their blood glucose and it's usually sky high and they're crook as a dog and you think, yeah, this is what's going on. Because of the action of this drug in terms of getting rid of glucose through the kidney, actually people's glucose levels were not as high as you'd expect. So you might measure it and their glucose might be 16, 17, and you think, oh, well, it's not ketoacidosis, they're sick for some other reason, so you don't twig to it necessarily. Now, so that's in people with type 1 diabetes, but there have been a smattering of cases now reported in people with type 2 diabetes as well, which is quite unusual because we don't normally expect to see ketoacidosis in type 2. So that's just the one thing that we just need to keep in our minds, just a little bit of a caution about this class of drug.
How great an effect on the blood pressure?
Meaningful, clinically meaningful. So in the order of sort of 2 to 5 millimeters of mercury systolic, which this is mean effect, which is about as good as most, agents that we put people on for blood pressure specifically. And again, of course, there's variability in terms of individual response. So certainly, not insignificant. On that note, that's another slight concern that has been observed as well for people in perhaps hot climates where they might be prone to a bit of dehydration. Actually, their blood pressures can drop quite significantly because they're peeing out all this sodium. So it's something you just have to warn people about in that circumstance. Okay, so again, just to rattle through this quickly, some of the benefits we're seeing in terms of this is a trial looking at the add-on to metformin and the impact of HbA1c. So meaningful and sustained reduction in HbA1c in that trial and some weight loss to go with it. So a difference of about 3 kilograms between the placebo group and the active drug group. And you're familiar with these plots now. So this is, again, the mean data and showing that the mean effect of this class is somewhere between 0.5 and 1%, so around about the 7 millimoles per mole reduction in HbA1c. So meaningful, perhaps not quite as great as the GLP-1 agonists, but a little bit better than the DPP-4 inhibitors. Gone over that really. Again, this is something that's lurking, been a little hint, a little signal that there may be risk of cancer, bladder cancer, breast cancer, but like the story with the pancreas in the GLP-1 agents, this is more smoke than real risk at the moment, but something that just needs to be watched. So the names of these drugs: dapagliflozin, canagliflozin, empagliflozin, and those are the doses of them. We have access to canagliflozin and dapagliflozin in New Zealand. Hopefully might get empagliflozin soon, and the reason that I say hopefully is that once again we have a trial reported last year on empagliflozin and cardiovascular outcomes in people with type 2 diabetes. And this is, I think, even more impressive than the data we saw from the liraglutide study: greater separation, greater reduction in terms of cardiovascular events. And I think quite convincing. Again, we don't know whether it's a class effect or whether it's specific to empagliflozin. But one would assume that it probably will be a class effect, a bit like ACE inhibitors, in the sense that the mechanism of their action is so specific that it's probably going to be a class effect, but who knows. So just to then taint the picture, and the reason that PHARMAC understandably and appropriately have been cautious about considering funding these agents is the cost. And we need to be sure that they're cost effective. So metformin, first line therapy, cheap as chips. Glipizide, other sulfonylurea, has been around for ages, a little bit more expensive than metformin, but really cheap as chips. Even pioglitazone is pretty cheap these days, but those you can see are indicative prices for what patients would have to pay if they're on them in New Zealand, paying for them privately. Around about $100 a month for the DPP4 inhibitors. Significantly more expensive for exenatide, double the cost, and the dapagliflozin you can get for about $90 a month through Pharmacy Direct in Auckland. But, big difference there. And if you were to go on to insulin, and just as a indicative dose of 30 units of insulin, of MPH insulin, is about half the price of one of these oral add-ons. So it's not there's a whole lot of good stuff here, but you have to weigh up the real cost and think, particularly as a New Zealand Inc., is there enough cost benefit to these agents?
So do you think it's likely they will be funded?
That's not a question for me. I desperately hope so. And I think that the data that we're seeing now in terms of cardiovascular risk adds weight to that argument. I think before that data, I think entirely reasonable to say, actually, given this cost difference, is there a real benefit here? But I think that cardiovascular outcome data is quite compelling, and I'm hopeful that we might see some movement.
So the Xenotide you said could be once a week preparation. Does
Yep.
it come down if it's once a week?
No, it's actually more expensive, unfortunately. Yeah. But the price will come down in time. But yeah, I can't remember the cost of the weekly Xenotide. Can you remember? It's more expensive again. I think it's over 300. Yeah. So just a summary of that. New agents, similar glucose-lowering efficacy as the older agents, but some advantages, certainly in terms of weight. Hypoglycaemia, which is very important, particularly in the elderly. You can use some of these agents in renal failure. Beta cell neogenesis, I think, just park that one really. I'm not convinced about that at all. The SGLT2s have this effect independent of insulin, so anything else that's going on, so good from that point of view. And now this new compelling data from the SGLT2s and the GLP-1 agonists in terms of cardiovascular risk reduction. Just a slight hangover in terms of cancer risk, but as I've said, the ongoing review of cancer registries is not showing this to be a real risk at the moment, but I think we still have to keep an open mind, cost being the biggest issue. Okay. So the other thing in the last few minutes that I wanted to talk about is some changes, some evolution, some new technologies in glucose monitoring. So we all know that for people with diabetes, particularly once they're on insulin therapy, that we want them to test their blood sugar themselves. We want them to understand that and to use that information to help self-manage their diabetes, and that's again another sort of holy grail for us, isn't it? Trying to get a person to the point where they're in control and in charge of their own diabetes, and monitoring blood sugar is a very important component of that. There's a whole host of reasons why people don't. And one of them is the fact they have to prick their finger and it hurts, and you do that enough times a day and you end up with calluses on your fingers, and there's a whole lot of limitations to it. It's also, even though it takes microseconds to do, it's having to stop what you're doing, do it, think about the numbers, etc. Doing it in a public place. All of those things are factors which contribute to people not testing as much as we would like them to do, and as much as they themselves would like to do as well. So any technologies, any advances that might improve monitoring of glucose, I think are likely to improve diabetes care and diabetes management. So one of the things that's been developed is this thing called a Freestyle Libre. Now, we don't have it in New Zealand at the moment, I say immediately. People can access it through Australia if you've got a friend over there who's got an Australian address, and you can get sent over from there. But we don't yet have it available in New Zealand. It will come. It's just there's a worldwide shortage of these things. So this is a new technology. What I'm showing there is the profile of the sensor, the tiny little cannula here. So these sensors are put on the arm. They're a little disc, and that little sensor goes into the skin, and you can see an example of it there. And you have this wand which connects remotely to that disc and will give you a reading of your blood sugar. And the cool thing about this is you just wave it over it and get the data, but it'll give you a trend. So it'll tell you not just what your number is, but what the trend of your blood sugar is. So if you're a 6 and you're going up, then you might want to do something about that. Or equally, if you're a 6 or a 5 and you're going down, you might do something differently about that. So it's added value than just a simple one-off reading, which is what you get from finger prick testing. You can, of course, download all of that data, and you can analyse it and look at the trends and patterns and so forth over time. So I think this is a really exciting piece of technology. We've certainly got a number of kids now in the region who are using them, and it's a godsend for them. You can imagine, poor little kids having to prick their fingers multiple times a day, mum and dad anxious, etc. It's making a huge difference for the management of their diabetes. Now, this is the sort of stuff that I think for people who have type 1 diabetes is a real breakthrough. People with type 2 who are using multiple daily injections of insulin and wanting to fine-tune their insulin therapy. I don't think it's the sort of thing that's useful for people with early type 2 or on metformin, or even sulfonylureas or whatever. That's not where this is going to be helpful or make a difference. This is technology which is useful for people with type 1 and people who are on intensive insulin therapy with type 2. So you can get it through Abbott Australia. You can order them online. Expensive, but not too bad. So the wand itself is $95. That's a one-off thing you buy, piece of kit. And sensors are $95, and each sensor will last for 2 weeks. And as I mentioned, at the moment it has to be delivered to an Australian address, so you need to have someone over there who can receive it and then send it on to you, which of course is going to add cost to the whole thing. But we've got a number of people now who are beginning to do this and finding it useful. The other technology are the continuous glucose monitors, and they've been around for a wee while, and they're evolving technology. The slightly annoying thing about that is that each time they evolve means the cost stays up. So they're not ever getting any cheaper, they're just getting better and more sophisticated. And these are a similar device, and the latest version of this is the Dexcom 5, and these are devices which are introduced and sit just under the skin, usually on the abdomen. You can put them elsewhere, but abdomen is the usual place where they're inserted. And this particular one is able to then remotely communicate to either like the wand you saw on the previous one, or to a phone. And of course the benefit of that, being able to go to a phone, is that actually for kids, parents can monitor what's happening with their kids' blood sugars remotely. That's a huge peace of mind for them. Or again, if you've got a loved one who's not perhaps looking after their diabetes as well, and you're helping them, etc. Those sorts of situations can make it easier. Also, I've had people say that you're walking around and everyone's looking at their phone constantly, and so to have this connecting to your phone rather than to something else you're taking out which draws attention is another way that people can monitor their glucose. It gives you a continuous reading, so once again the benefits are that you get these trends of what's happening with your blood glucose, but also you can set alerts on them. So for people who have unawareness of hypoglycemia, which can be a big problem for people with type 1 diabetes, you can set it so that it will alarm and alert you if your blood sugar drops below a certain level, or equally a high level. You can be wandering along not knowing that you're sitting at 12, 13, 15, whatever, and it will alert you. You can set that level so you can do something about it. And once again, you can download all of that data and print it out and look at trends and other bits and pieces. So again, exciting technology, but comes with a cost. And you can see a huge difference here, huge difference between this technology and the Freestyle Libre in terms of the cost. Each sensor lasts for 7 days officially, but people are definitely getting 2 weeks out of them often. As you can imagine, if you're paying this much for a sensor, you can eke out as long as you possibly can. But a quantum difference in terms of cost for this technology. So I think if we are looking again New Zealand Inc. perspective, if we're wanting to say to PHARMAC, well, hey, how about funding some of this for selected groups of people, it's a no-brainer to me that the Freestyle Libre is going to be the thing that the technology that I think potentially could be considered. So that's all I have for this morning. An update, as I say, focused very much on the newer agents and on some of the newer technologies. And I think I've got 30 seconds for questions.
So, thank you, Jeremy. That was amazing. You're the perfect speaker. You arrived early and you stuck exactly to time.
Early for me, anyway.
Is there any questions for Jeremy?
Just one with regards to the newer agents. The studies have obviously looked at them in isolation or in conjunction with
Yes.
metformin. Have there been studies
Yes.
with newer agents with each other?
Yeah. So they've limited at this stage. So all of the trials that came through initially, they were paired with metformin for obvious reasons, and then there've been some other add-on studies where it's looked at it with triple therapy and in combination with various other things. So if a person doesn't tolerate metformin, for example, and they're on a sulfonylurea, there have been studies which have looked at them in comparison to that. I'm embarrassed to say that I can't recall studies where there have been head-to-head trials of, say, a GLP-1 agonist against an SGLT2 inhibitor.
So not even in comparison to each other, but even just seeing if there's a synergistic effect to be used in conjunction with each other. And it sounds like they're pretty new.
Yeah, there possibly are. I just can't recall off the top of my head. Quite obviously, as you're alluding to, I think any agent, if you combine it with an SGLT2 inhibitor, is likely to have a synergistic effect because the function, the action of the SGLT2 inhibitor is so unique that there's not going to be a negative interaction with other agents. Yeah.